Hello everyone, and welcome to the 7th week of the COVID-19 webinar series from Henry Schein. I'm Dr. Gary Severance, and we certainly appreciate all the views, the questions, and the comments this series continues to generate. Please add your comments below, or if you're watching this on the premiere, you can chat amongst your peers on the right. Let's go directly to Dr. David Reznik now for his clinical update.
Thank you, Gary, and it's a pleasure to be back once again to talk to you about some clinical updates of some new findings that we're seeing, and then hopefully some things that'll help get your practices back up and running in a safe and secure fashion. So the first thing I want to talk about today is that the CDC did announce some new symptoms. And so this helps you screen patients. It also can help you in communities and people that you're in touch with. So you have an idea of what some of the symptoms associated with this disease are. So remember, the symptoms can start between 2 to 14 days after the exposure. We look for a fever that's greater than 100.4. Shortness of breath or difficulty breathing. These are some of our existing signs, and dry cough. The new ones that have been added to the list are chills, repeated shaking with chills, muscle pain, headache, sore throat, and then the one that we talked about a few weeks ago, loss of taste and smell, has finally been added. There are a few other things that you can look for that have not been added to the CDC list, but there's something called COVID toe, which is like a purple area on a toe. So there are all these different manifestations that are beginning to show patterns, and we're going to be adding them to the CDC list of symptoms and things that we need as providers and dental team members to really know. So with the new information that's out there, with the new symptoms, is there really anything different that we need to be doing that we should already be doing? And to be frankly honest, the answer is no. Washing your hands frequently for 20 seconds. Remember to cover all parts of your hands. I know I say that often, but I see people in the bathroom and at the clinic that aren't doing 20 seconds and they're not washing their hands as getting all the surfaces. So please do that. Maintain physical distancing. I really don't like the term social distancing. I think we need to maintain our social contacts. I think it helps with sanity during trying times when people are stuck at home. It also just lets us enjoy a part of our normal lives. Avoid touching your face, and that is really difficult as people. We touch our eyes, nose, and mouth a lot during the day. So wearing masks at all times is helpful. That does help you prevent from touching your eyes, nose, and mouth. And at the hospital, we do have a policy of wearing masks at all times. Practice respiratory hygiene. Remember, cough into your elbow, cough into a tissue, and immediately throw it away. Just things that we should be doing on a regular basis. If you start having some of these symptoms and you are concerned that you might be COVID positive, call up your primary care provider right away. Don't go to their offices. A lot of us are still not really open, even on the medical side. So they're doing telehealth visits. I had a telehealth visit with my back doctor, which was a great visit. So you can talk to your provider and they'll give you advice on what to do, and stay informed. So please keep watching these updates and any other updates so you can protect yourself and your families. So over the weekend, the ADA did come out, the American Dental Association did come out with interim return to work guidelines. So since it's interim guidelines, they're only going to be for a period of time until we can adjust to the COVID epidemic. And as long as we go through this, the more time we go through this epidemic, the more we're learning. So the more specifics that we'll be able to offer. Details that are not specifically in the ADA document are left up to the professional judgment of each dentist. You'll see that in almost every state association and of course, the American Dental Association, National Dental Association, Hispanic. The possible integration of dental infection control measures, air purification systems, and other safety recommendations will be addressed by the Council on Dental Practice as the knowledge grows. I will tell you that my concern, as you've all been hearing this entire time, has been with the aerosol. and that I'm not going to reopen until I know that I have addressed the aerosol as best to my abilities. So right now, just like many of you out there, where our program is only seeing emergencies only, but we're starting to plan on what can we do when it's time for us to get the programs up and running. It's time to start thinking in a positive fashion. We've been down. We might be getting up soon. How are we going to do this, and how are we going to do it safely? So having an ADA workforce or planning committee come together to offer this advice is actually very timely and very helpful. One of the things that I've already seen out in public is a welcome back reassurance letter. And so I think it's really important because during this letter, if you want to go in the mail format, you can tell how you center, how important infection control is for you, how you're there to provide safe care for your patients, how there will be some differences in the experience, that you might get a call beforehand or possibly a text beforehand asking you specific questions, and we might go over some of those questions. Letting them know that there's hand sanitizer in the office, and that maybe there won't be magazines in the waiting room, and the waiting room will be set up differently, and that appointments will be set up differently, and even things like you might be waiting in your car and then we'll call you or text you when it's time to come in. So we really are doing all the steps possible, and whether you want to do this as a letter, which is what I have seen, or an electronic format, which I've also seen, because I do have a procedure, or I did go to one of my medical providers for a procedure, and before I walked in, it was in an office building. Before I got into that office, they scanned my temperature, just like they do when I come to work every day. So that's something that we're going to have to start letting our patients know is going to be part of routine. So in the pre-appointment screening, we'll ask some of those basic questions that we went over for symptoms, the shortness of breath, the fever, a dry cough, and some of those new things, chills. If somebody has chills and a fever, they're probably not going to want to come to the dental office. Inquire about underlying medical conditions such as diabetes, hypertension, heart disease, which are known to be exacerbate the outcomes of the disease. Have they been in contact with someone that has known COVID-19? Have they traveled in the last 14 days to areas hit hard? And that doesn't mean out of country. That could be within country. This is my least favorite. Are they over 60? I'm personally over 60, and I'm doing my best to stay healthy, but it's people who are over 60 who do have some of the more untoward outcomes. So if you answer yes to any of these questions, or the patient answers yes, then you have further questions that you need to talk to the patient about. And then you need to let folks know that we're asking these questions for their own safety. So we do it on a pre-call. They're going to ask the same questions when you show up to the office. That's happening in routine for medical work now, and it'll be routine for dental work. Remind patients that we want to keep the waiting room safe and limit companions. So there are times I have a whole family show up in my waiting room to see one person, and we're calling up when we do reopen and letting folks know that please just limit the number of people. I'm in a blessed program that I work in, so we do have child care services, but we're really trying to do our best to limit the number of folks so we can promote safety. And if suitable, given your office design, you might want to put, tell patients, like I mentioned earlier, if you have a small waiting room, like I have a small waiting room, you might want to wait in your car if at all possible, and we'll text you or call you when it's time to come in, or in different places in an office building that might have more air or more circulation. It really depends on what works best for you and your program. As far as temperatures, the days of oral thermometer use are probably limited. We should look at different kinds of ways to check out the temperature. Forehead scanning is one. There's also ear devices that can take temperature, and the tips are disposable. Again, have hand sanitizer present, and then document it that the patient came in and their temperature was whatever. And it's going to be important to learn the differences in what the readings are for a forehead thermometer, infrared forehead thermometer versus an ear thermometer versus an oral thermometer. So you have a patient in the office. What do? You want to screen for some of those symptoms. You want to offer hand sanitizer. That's one area I've been ahead of the game. We have it outside of, I'm in an office building. We have it outside the front desk. We have it outside the entrance to the oral health center. Make sure that you have tissues available, and make sure that there's a trash can available. Their patients can throw tissues if they cough, sneeze, etc. Remember, we've already talked about this. Please toss your old waiting room magazines, wipe down hard surfaces regularly in between. So we're so used to doing infection control procedures in the clinical areas of our programs or our offices. Now we have to take some of those same things that we've learned and we've done for years and years and years in the clinical side and now put that into the waiting room side. So we're really trying to make sure we have the best infection control possible, and that'll make our patients feel comfortable and know that they're getting the best service. Gowns. So, with regards to clothing, and this actually applies to all members of the dental team. So I'm not just talking about dental assistants, dental hygienists, dentists, dental therapists. I'm actually talking about front desk folks as well. When I was in private practice, my mother was at my front desk. So if you assume that it's your family at the front desk, you want to take as much precaution as possible. So our front desk folks will be in our gowns as well, if available. If gowns become soiled during clinical work, please change them. Disposable gowns should be discarded after use. Cloth gowns should be laundered after each use. Scrubs. And this is important, and a lot of people I know do this, but a lot of people, sort of gotten lazy over the years, I think, or are used to doing it in a certain way. But if you're wearing scrubs, come to work in street clothes, change into your scrubs upon entry and exit, and do the same with other office garb. These are basic tenets of what we've been doing for our entire professional careers. If you're able, provide laundry services in your offices, or you might contract with laundry services, which is another option. And please cover up your arms. When we're working on patients, make sure you have no exposed skin. And then, of course, an ADA statement, professional judgment should be exercised with regard to the use of disposable foot covers and head covers. I will slightly disagree with the ADA here, I think, because of the droplets that form and the aerosol that will stay in the air and eventually drop to the floor. I really wish we would wear foot coverings and dispose of them on the way out. And that is not in between each patient. We're not trying to disinfect the floor between each patient. It's so you don't bring things home. That's the main goal there. Our key really is to ensure patient safety no matter where they are. So we want to limit the number of people in the operatory. That's something that I've done my entire career, but we know there's those instances where people want to have family members in, or translation services in, or somebody from the family that can translate for you. In public health, we actually have a guideline where we have to have people that translate. So you want to limit the number of folks in the operatory. You want to reduce the amount of paper in the operatory. And we're really trying to go paperless these days. Again, practical infection control advice: cover your keyboard and mouse with surface barriers. Remember, I talked about the mouse being one of the more areas that is the highest level of COVID contamination. And protect during aerosol generating procedures. Please have in place some mechanisms that will address it. I have honestly spent a lot of time looking at the different devices. Please meet with your representatives, from Schein or from whatever companies that you purchase your equipment from, and look at some of the options that are out there and look at what's best for you. As I said earlier, the ADA will be coming out with some recommendations. My concern is that I've got to get up and running, and some of these products won't be available until the end of the month, end of May, and some might not be able to even later than that. So my goal is I want to try to get my decisions made as soon and as quickly as I can, with a lot of advice from the retail sector, because this is not an area of my expertise, and then try to get this in place so when I do open, I open as safely as I can. Remember, when performing any aerosol generating procedure, please have on N95s. That is really important. When the patient leaves the office, besides your post-op sterilization and infection control procedures, remind the patient if they have any symptoms or signs of COVID-19 within the next 14 days to call the office, or have someone from their family to call the office just to let the staff know. Again, my whole component here, if we're doing infection control and we're looking at transmission-based precautions and standard precautions, we should be fine. That it's making sure we have our masks on appropriately, our shields on appropriately, our skin covered. Do the common sense things to protect you, the dental team, and your families. And then a lot of this information can be found at the CDC interim infection control guidelines that we've sort of generally covered over a period of time. Patients in the office, what to do. We've already talked about, but what happens if you have a pregnant staff member? And this is very important. Pregnant staff members should seek and follow the medical guidance from their physician regarding work. So one of the programs that I work with, have residents at, that is only seeing emergency patients at this point. They're dealing with this. The OBGYN actually wants the dentist to stay at home, and I think that that's fine. That's wise. We want to make sure that the staff members have healthy and successful pregnancies. Information on COVID-19 and pregnancy is limited at this time. As you can imagine, we've only really known about this epidemic for a few months. So offices may want to consider limiting exposure of pregnant staff to patients, especially during higher risk procedures. And when I say a higher risk procedure, I'm really talking about aerosol generating procedures. And this is based on the guidelines of risk assessment for public health management of healthcare personnel, as also the resources, the American College of OB/GYN. So once again, thank you for your time. I do want to talk about some other resources that are out there. The ADA and OSAP, the Organization for Safety, Asepsis, and Prevention, does have a webinar out there that is very good, and it's based on some great colleagues of mine, Eve Cooney and Kathy Eklund. Again, thank you for your time and attention today. It's always a pleasure. And Gary, back to you.
Thank you, Dr. Reznik. Always interesting and always changing. Now I'd like to welcome Michelle Strange, a hygienist, an educator, prolific author, a great podcaster, and a passionate leader for our profession. Michelle, I'm so happy you can join us today and address what is probably the most dangerous part of our profession today, the presence of aerosols. Welcome.
Thank you, Gary, for the introduction. I'm excited to be here with Henry Schein today. You know, my history as a surgical assistant and hygienist, I've been a big fan of air powder and aerosol procedures, and I've had to kind of learn over these days or over some time to find the best protocols out there and really dive into the research. So I first wanted to start by reviewing some terms. The CDC reminds us that instruments used frequently in routine dental procedures, including rotary, high and low speed dental handpieces, air abrasion or air powder techniques, sonic and ultrasonic scalers, and then of course your air polishers and air water syringes. All of these produce an aerosol or spray or some kind of dental splatter. And depending on the dental procedure performed, aerosols from any of these instruments have the potential to contain droplets of water, saliva, blood, microorganisms, and possibly other potentially infectious materials. And so dental aerosols and splatter, they're going to travel through the air and they will probably settle on treatment area environments, your equipment, maybe the patient, the dental personnel, and even the floor. And the powder or the spatter can commonly be seen like on your face shields and even your eyewear and other surfaces right after that dental procedure. And eventually they do, and usually within a short time, clear or dry clear, and they're not really easily detected. Spatter and splatter sometimes feel like semantics and are sometimes used interchangeably. And I've asked forensic dentists and others, I seem to get a different definition from everyone. What I understand is that spatter and splatter are both over 50 microns. there, is not a real standardization for these terms sometimes, which does make it a little confusing. And of course, the colloquial term for aerosols just means any particle that kind of is remaining airborne for any length of time. So aerosols, we can't see with the naked eye. The spray created from our devices may also contain some aerosols, and aerosols, they take energy to create. So, and they consist of like particles less than 10 microns in diameter. Again, you can't usually see that with the naked eye. And aerosols can remain airborne for extended periods of time and also be inhaled. Aerosols should not be confused with, again, that large spatter and spatter, one with a P, one with an L, that makes up the bulk of the spray from things like our hand pieces, our ultrasonics, and our air water syringes. The EPA and many health organizations categorize this particulate matter by size because different size particles have a different health effect. So, for instance, a PM, which stands for, it means particulate matter, of 10 particles, that means particles less than 10 microns in size, those can irritate your eyes, your nose, and fewer of those particles, a few of them can actually penetrate deep into your lungs. So they do not cause the same health problems that these like super small micron particles can, although they can increase rates of respiratory disease. And particulate matter is given the name because it's a complex bunch of these small microscopic pollutants that float in the air. And PM is commonly measured in microns, like I've mentioned, or a micrometer. And 1 micron is 1/1,000,000th of a meter. And particulates are often divided in 2 basic groups based on their size. So your PM of 10 is considered coarse, and your PM of 2.5 is considered fine. And these include pollution, dust, pollen, pet dander, viruses, bacteria, even mold spores. Particulates are often divided into these, like I said, 2 sizes, 10 or 10.5. And then you can even have something like ultra fine, and that's usually less than 0.1. So think gases and things like that as well. And have you ever just sat down after cleaning the house and you feel like you've accomplished something and then the sunlight just shines just perfectly and you see these little particles floating in the air? Well, the naked eye, like I said, can see those 50 plus microns. And we know the nose is pretty good at filtering those larger microns. And just to give you a visual of these particles, the human hair is about 100 microns. I've seen in the literature anywhere between 80 and 100, which makes sense because some of us have thinner hair than others. But you can also look at like pet dander that runs about 80 microns, pollen, and that pollen can range anywhere from like 30 to 80, just depending on the plant that it came from. Dust mites, that's something that gets me quite often. They're pretty small. And then we have our little tiny guys like bacteria, smoke, and viruses. And again, our nose can filter out so much, but we sometimes need a barrier, an additional barrier over our upper respiratory system, like our nose and our mouth, to protect us from inhaling those smaller particle sizes that can enter our respiratory tract. And when we think about the respiratory tract, that is a mode of transportation. And I just wanted to review the chain of infection and how do we break that chain. So when we have an effective infection control strategy, we break it at multiple places. And so if you think of it as an actual chain, it's got 6 different links, and each link has a very different or unique role where you can break it in various means. And the CDC discusses actually a lot of this in their principles of epidemiology. And they talk about that human reservoir, which is often, where it can start. It can obviously start with animals as well. And we know that human reservoirs may not always show the effects of an illness, as we've learned with COVID. And then we have the portal of exit, and that's the path which the pathogen leaves that host, which usually corresponds to the site where the pathogen is localized. So if we think about the flu or Mycobacterium tuberculosis that exits the respiratory tract. And this is where it's usually localized in the host. And then you have that mode of transportation, being the respiratory tract being one of them. And it can be direct or indirect. So many of us are now familiar with droplet mode or mode of transportation. And it's classified as direct because transmission is by directly spraying it over a few feet. Coughing, sneezing, even talking can be a direct transmission. So things like pertussis and COVID-19 infections are examples of diseases transmitted from an infectious patient to that susceptible host by a droplet spread. And then we have the portal of entry, and that is going to refer to where that pathogen actually enters that susceptible host. And often infectious diseases or agents or pathogens use that same portal to enter a new host that they use to exit the host. So again, an example being influenza virus, it exits that respiratory tract and then will enter a respiratory tract of the new host. There's a few exceptions to this. And when we look at like gastroenteritis, because there's that so-called fecal oral route where, they have unwashed hands and maybe it gets on somebody's, or maybe they eat with their unwashed hands. And so that now becomes from, fecal to oral route. So not the same, but so that's your little caveat to that. And the final link in the chain of infection is your susceptible host. And some strategies that protect that portal of entry are really simple and effective. For example, our gloves and mask are intended to protect the dental professional from blood and secretions and droplets, as they're also protecting the patient from us, the dental professional. And, quite honestly, the susceptible host is why I personally break the chain of infection as often as I can as a dental provider. And so we want to make sure that we're not creating harm when we're treating our patients. And so breaking this in as many places is super important, especially when we're creating those droplets and aerosols that we often do in dentistry. So in dentistry, the diseases that we're concerned about are those caused by bloodborne pathogens. We actually have an entire standard for this from OSHA. And examples are, your hepatitis B, hepatitis C, and your human immunodeficiency virus, which is HIV. And the transmission may occur from that patient to the dental provider, from the dental provider to the patient, and even from one patient to another patient. And the best way to prevent that transmission of a bloodborne pathogen is to adhere to things that are to the standard precautions that we have had for many years now. Although it is known that the bloodborne pathogens can be transmitted through mucous membrane exposure, there are no known instances of a bloodborne pathogen being transmitted via an aerosol in a clinical setting. And in studies conducted in the dental operatories or clinics, and even some hemodialysis centers, the Hep B surface antigen, it could not be detected in air during the treatment of Hep B carriers, including those procedures that were generating aerosols. And so, they're not as worried about it being aerosolized as some other things that we are worried about. And so the possibility that HIV may be transmitted or Hep B via aerosols blood, it's really more considered theoretical. And these bloodborne pathogens, they really can't be compared to our airborne pathogens. So airborne pathogens, or these pathogens, they create airborne diseases because microbes are so small. They're small enough to be discharged from an infected person via coughing and sneezing and laughing and singing and speaking, and even just close personal contact. And they aerosolize that microbe, and the discharge of these microbes, they remain suspended in the air on dust particles and these respiratory water droplets. And the illness is caused by, when the microbe is inhaled or it contacts that mucous membrane, or when secretions, they remain on a surface and then we go touch that surface. And so transmission of airborne diseases, they can be greatly reduced by practicing, social distancing, staying home when we're ill, keeping close contact when a person is ill, or allowing just a few feet distance when you have a cough or you might be ill, wearing a mask, covering your cough and your sneezes with your elbow or tissues. Also, good hand hygiene can decrease spread of the germs or pathogens in the droplets. And all of this sounds very familiar to what we've been asked to do in the last few months, but with COVID. But it has always been recommended for any respiratory illness. So our environmental controls and our engineering alternatives, they help to reduce that transmission of that water droplet aerosolized pathogen when treating dental patients, if that needs to be done while they're actually ill. And so aerosols generated in that dental treatment area, they create this potential risk for disease transmission to like immune compromised patients and other dental personnel, especially if they're also immune compromised. And reduction of that transmission of infections from the aerosol and possibly contaminating the environmental surfaces in all healthcare settings, including your dental treatment areas, it's really best accomplished by incorporating some of the recommended guidelines and standards that we've had in dentistry for many years. And in this 2018 article on dental aerosols, the author points out that we are regularly exposed to tens of thousands of aerosols that are generated during our procedures. And this, without a doubt, increases our risk for respiratory infections. Those respiratory infections are highly communicable and have been linked to some microbial inhabitants of the oral cavity, as noted in this article. So, yes, we need to worry about COVID and what life will look like once we return, but we should also be concerned with all of these respiratory airborne diseases, the flu, common illnesses like that common cold. We don't have a lot of contact tracing happening in our dental industry. We aren't tracking every time someone gets the flu to see where they could have contracted it. We don't always call the patient 2 to 3 days after an appointment to make sure they didn't contract the common cold. I wish we had more occupational data in dentistry, but in my opinion, we just don't really have enough. And it would be so wonderful for us to get more information on these airborne illnesses and if we are a possible vector for that. But we just don't have a lot of data on that. But in this 2016 article, looking at dental practices as a neglected vector, the authors remind us that there are 4 basic routes of spreading harmful microbes. I already mentioned bloodborne and also saliva droplets and aerosols. You do have your direct contact and also dental unit waterlines. And we will discuss that. But it's also a forgotten place to possibly contaminate us and our patients. In this 2011 study, the authors stated that there's very little known about the quantity and type of airborne microbes in the dental practices. And they can have different origins and can even come from the dental team. And in fact, again, we talked about the dental healthcare worker infecting the patient infecting the dental healthcare worker. But we can also appreciate that we as dental healthcare workers can infect each other as a team. I think a lot of us probably have experienced when somebody came in with a cold and it took us all out as a team. We all kind of just passed it back and forth to each other. Also in this 2017 review on bioaerosols, it brought up a point that I have wondered about for years. Most of the studies in dental practices focus on bacteria and not viruses in the generated aerosols. And the authors, they go on to state the data might be an underestimation of reality, since the studies look for very specific microorganisms, and sometimes they're missing because they're not looking for them, other microorganisms that could be present in those bioaerosols that we're producing. And this 2004 review from Dr. Harrell and Dr. Molinari, it's cited frequently in literature. Actually, I always kind of come back to this one when I'm reading, the literature in the last 10 years or so. And they brought up that it's reasonable to suppose that there's contaminants of saliva and nasopharyngeal secretions, plaque, blood, tooth components, and other materials that we use in our dental procedures, like our abrasives, like so there's air powder, or air polishing powders, and they're all present in that dental aerosol. So there's a lot going on in this plume that we create. And also, they bring up that saliva and the nasopharyngeal secretions could contain these other pathogenic organisms. And they even bring up SARS, that virus of COVID-1, the first SARS that we had years ago. And we know that splatter and droplets have been implicated in the transmission of other diseases, not necessarily in dentistry. And we know we create splatter droplets every day on almost every patient. And so we have to take that into account. We also have to take into consideration the infection we could give the patient via dirty dental unit water lines, as it is a part of this ubiquitous aerosolized cloud that we create during these dental appointments. So in addition to all those tooth parts and plaque and blood and saliva, we have some things happening in our dental unit water lines that can create a contamination. And so we're dealing with almost invisible aerosols, and it has always and will continue to be important to minimize or eliminate as much as possible during our clinical situation. And we'll talk about that further in detail. I would be remiss if I didn't bring up standard precautions. So universal precautions has evolved and includes these standard precautions. They are the minimum infection prevention practices that apply to all patient care, regardless of any suspected infection status of that patient. And any setting where we are actually delivering healthcare, we should be practicing standard precautions. They're designed to protect us. They're designed to prevent spreading of infections among patients. And they include hand hygiene, your PPE, so your gloves and your mask and your eyewear, that respiratory cough etiquette that I mentioned, is sharp safety, safe work or safe injection practices and safe working practices, sterilizing our instruments even. And when a patient presents with symptoms of an infection, standard precautions alone might not be adequate to prevent that transmission. And you can find more of this information on CDC's website. So in the situation where standard precautions are happening, but we have a possibly infected patient, we have an additional tier called transmission-based precautions. And they include your contact transmission, your droplet, and airborne. And it's going to be really important to add this in addition to our standard precautions. So your droplet transmission, for instance, that's going to talk about any particles or anything that can be spread larger than 5 microns. So that's something that happens when we generate a cough and a sneeze and talking. And they can be, like I mentioned, directly transmitted to the respiratory tract. And the flu is one of those examples. And then when we look at airborne transmission, that's usually particles smaller than 5 microns, and they can remain infective over time and cover some distance, and they can be dispersed over, long distances because of air currents generated by, our air conditioning systems. They can definitely be inhaled without direct contact of that infected individual. So this is like measles and chickenpox, TB, and eventually we'll have a better understanding of where COVID falls into that. But right now we're practicing with our additional transmission-based precautions. Currently, we are not operating under conventional CDC guidelines while we are in crisis or contingency capacity. It is, however, a great idea to familiarize yourself with these, which is the CDC's basic conventional guidelines. They are the minimum recommendations that we should work with. They were updated in 2016, and you can find these at cdc.gov/oral health. They give you all that information on standard precautions, and they will walk you through all the different things of hand hygiene and PPE and sharp safety. That is, again, the minimum requirement. So we have established controls to reduce our risk of exposure. You see some of these controls in our OSHA plans, and you see some of them under CDC. They have a lot of crossover and a lot of cross-pollination. Traditionally, a hierarchy of controls has been used as a means to determine how we're going to implement things feasibly and effectively. And the hierarchy ranks controls according to their level of reliability, and they include engineering controls, our administrative controls, and they end with our PPE, our personal protective equipment, because they are the least effective control, because it involves a high level of worker involvement, and it requires us to wear it properly, to be fitted properly, and to use it consistently. But if we have these engineering controls, they're going to be super helpful, and I want to talk about that a little bit more. Because these engineering controls, they do help us reduce aerosols and droplets. There's all kinds of engineering controls in dentistry. Sharp safety is one of them, or Sharp's containers and safer needle devices are part of our engineering controls. One that we don't always talk about until now, I think it's getting a lot of attention, is our high volume evacuation. Now, the thing I want to talk about is training. Training is a must for our engineering controls. I'll again take high volume evacuation as a great example. If you haven't used it in the past, it can be a little cumbersome. I've slapped my patient in the face with the tubing about a dozen times the first time I tried to wield it by myself. We have to train to competency on these items so that we can use them efficiently, especially during a crisis when controlling the aerosols could reduce this risk of serious disease. And this is a great time to just slow down, to make sure the entire team is actually trained. So again, going back to the high volume evacuation, are we all trained and we understand that HVE should be held opposite the device that we're using? So if it's a handpiece, or if it's an ultrasonic, or if it's an air powder device, not just right now in this pandemic, but always, that's how it should always be used. So if I'm working on the lingual aspect, I need to make sure to hold that on the facial aspect. It needs to be also held pretty close to the source. And if it needs to be pulled away, so maybe if I'm assisting or I have an assistant, if I need to pull away, then the production of those aerosols needs to stop so that we aren't missing any of those. Now, extraoral suctions have been around, but are definitely gaining more popularity. I personally would love to have this little robot assistant to help me during my hygiene appointments. I dreamed of it, but it can be costly, especially if we weren't really looking at aerosols before. Now we are, and now this might seem like a really great investment. It's really hard as a lone provider to deal with the pooling of water in the back of the patient's throat and the aerosols. And something like that, this can be set pretty close to the patient to capture those droplets and aerosols as they're being produced. It's hands-free, just kind of prop it up there, and it's going to help you do the work. It's like having this, like I said, a little robot assistant. And so that is definitely an option that, like I said, is gaining a lot more traction these days. And many of us are more accustomed to the intraoral suctions. These particular ones on the screen are to create a dry field, and they're attached to your high volume suction or evacuation. They create this dry field mostly on one side of the mouth, and some have lights to illuminate even the darkest corner of the mouth, while it also retracts the tongue and the cheek, which again is so nice if you're a lone sole provider, because again, we've wrestled tongues and cheeks while we're trying to get the aerosols. We need 4, 5, 6 hands sometimes. So this is really nice because it kind of takes out the tongue, the cheek, gives you a light possibility, and will create that dry field. And I can say that I use these, but I don't use them for every patient. For me, I have noticed that not everyone can tolerate these. Not everyone can open wide enough or have even the dentition to support the bite block, as I've experienced with a few of my patients. But when they work really nicely. So this is a possible option that you can use to help control the environment while you're working and create that dry field. We have had handheld intraoral suctions for a while, and we're probably all very aware of these. There are a variety of evacuation tips available. And the typical plastic pieces with, they have this large bore, a large opening. They can come in different angles and vary from round to square openings. Some even have mirrors. Some even have lighter tubing that come with it to help with the drag on your wrist. Some are even designed to rest in the patient's cheek for that hands-free experience so that we don't have to grow 4 other hands. And it's important to note that not all of these are going to work the same. Some will work better at the pooled water in the back of the cheek or in the back of the throat. Some may work better with your particular vacuum unit, depending on how strong it is. And some will be clinician, patient, and procedure dependent. I personally have not found the holy grail of high volume evacuation. I have a few that I tend to jump back and forth to depending on my need. Often I may use even 2 at the same time. So for example, if I have a dry shield device you saw in the last slide, and that will, doesn't always grab the aerosols in the anterior. So I'll use that to help with the pooling of water. And then I'll use a second high volume evacuation to grab that spatter and aerosol that's being produced as I come to the anterior. So now if you're working on just a single tooth, if you're a dentist doing that, or if you're a hygienist, they're very different procedures. So if you're a hygienist doing this by yourself, you might need that second high volume evacuation. And again, if I have four-handed dentistry, if I get an assistant, that's great. But you just know that none of these are one size fits all. You're just going to have to be like Goldilocks and go find that right one that's going to fit for you. And that might even change from patient to patient and procedure to procedure. But just, find the one that works for you. There's so many out there. Test a few and, and share the wealth with your fellow colleagues, because we're all looking for a great solution right now. And so for many years, I used just low volume evacuation. I didn't have all the fun new suctions, and it was really extremely difficult to hold, that high volume evacuation while needing a mirror, using an ultrasonic, and trying not to drown the patient. So if there's a dental assistant to help with that procedure, this is often not a concern. But as, again, a lone provider, I was having such a difficult time with it. And it was not really great from an ergonomic standpoint. And so the low volume evacuation, there's so many ones out there as well. There's even these accessories that can help you, hook it. Well, what we call fish hooking sometimes, fish hook it and rest it in the corner or in the cheek of the patient so that they can capture that excess water. We even sometimes have our patients be our assistants where they're holding it. And there's plenty of devices out there that will help you with that pooling of water, and your low volume evacuation is definitely a big part of that. The thing about low volume evacuation is that they don't catch a lot of that spatter and spray or aerosols, and we just can't let our patients close on it, as you see in this video. They just close their lips around it, and a lot of them do it. It's just second nature now. But if we don't have a backflow preventer, we have got to stop asking our patients to close their lips around that. So many years ago, the CDC addressed backflow. Backflow, as you may have heard, it's when that previously suctioned fluid is in that dental tubing and it flows back into the next patient's mouth, which is so gross. So backflow often occurs when the suction tubing is elevated above that patient's mouth, because gravity, it's low volume. It doesn't have as much suction. So gravity takes hold. And the CDC advises dental professionals to contact the manufacturer of your dental unit to review that proper use and maintenance procedures, including the appropriate cleaning and disinfection methods of your suction units. And then OSAP, which is the Organization for Safety, Asepsis, and Prevention, they also cite leading infection control experts and regarding daily maintenance of that evacuation and backflow concerns. And there are a few of these backflow preventer or protectors on the market. Some will replace your valve on your low volume evacuation, or some will just snap into it and sit on top of it as an accessory. But you can have a patient close, or if they accidentally close, like some of my patients, like I said, it's just second nature. They do it before I can even get out of their mouth sometimes. Now I don't feel as scared about them getting that backflow if I have my preventer on there. So I mentioned ergonomics were an issue, and with these high volumes sometimes, especially with the tubing being very heavy. Even as an assistant, it was heavy on my wrist. And then as a hygienist being a lone provider, I mean, that it was just really awkward, and it started to make my wrist ache after a while. So in addition to chemical and infectious hazards that we are, introduced to as dental professionals, we have these physical hazards that are a concern. And we need to make sure that our engineering controls aren't causing issues and with our ergonomics. So these are just two great devices that I have used. One connects to your chair and lets you hold the high volume evacuation or hold the low volume evacuation just kind of there next to the patient, so you're not having to pull it and wrap it around. Also, there's one that's a bracelet or goes on your wrist, and it attaches, and it just truly takes that drag off of there. So if this is a concern for you, just know that there are solutions out there. You don't have to suffer through it or potentially put yourself and for the chance of getting carpal tunnel or having some issues later on and pain down the line. So in addition to preventing cross-contamination, proper maintenance of the entire vacuum system, it's going to make sure it works properly. So if we are always taking care of our high volume evacuation and our dental suctions, this is going to prevent costly repairs. It's going to prevent weakening of that suction system. And if the systems start to deteriorate, they're not going to pull as many of those aerosols from the air and catch that spatter and splatter that we're creating. And so we don't want to work harder. We want to make sure all of our equipment is working as it should for us, to serve us. And so just know that there's a lot of products out there. They are going to clean and disinfect evacuation lines. And you should always follow the manufacturer's instructions for use. They must be compatible with the EPA because there is this amalgam separator 2020 installment requirements. And it tells you that you cannot use bleach in your suction lines because it could create a pH issue and react with mercury. So there's very specific things that you need to use in your suction lines, and it's very important to follow those instructions for use. Also, you can test your vacuums. According to Rella Christensen, you can use a 1 liter bottle filled with water, and when you place your high volume evacuation in that bottle, it should suck that water out within 8 seconds. And so that's a good way to test and see how well your lines are doing. And if they're not working optimally, it might be a good time to call your technician and have a check of your vacuums. Also, we want to pull off the valves that we're using. This is actually included in many dental equipment's instructions for use. The lines should be cleaned and the valves should be pulled apart, lubricated, and autoclaved. Don't forget to also change the traps on each of your units so you can, again, have the best suction ability. And if you're going to use your high volume evacuation, we want all of this to work to its fullest capacity. So we're going to have to check these things and check those lines and clean them on a routine basis so they don't get all gunked up and, again, stop serving us. I also want to touch on rubber dams. They're also an engineering control, because engineering controls are just these additional devices that were designed to create a barrier between us and a potential risk. And the rubber dam, it's used to isolate that operative site from the rest of the mouth. And I've seen it used mainly in endodontics when I've been practicing, also for like crown and bridge placement and maybe just larger general restorative treatments. Its purpose is to, both prevent saliva from interfering with all of that dental work that we're doing, and also prevent those instruments from being dropped in the mouth or inhaled by the patient or possibly swallowed. And this really is a great option for dentists, but for obvious reasons wouldn't work very well for preventive or periodontal maintenance appointments with the hygienist, but it's definitely an option for you. I did want to talk about face shields. Face shields are such a big topic right now. I wore one before I had loops, and then I stopped because I couldn't get them to fit over my loops. I had a glare, but they've really come a long way in the last decade. And now you can find them to fit around most of our loops and lights. They're great at protecting your eyes, but also preventing your mask from getting wet. And we know mask porosity changes when it's soaked with moisture, and it can possibly reduce that filtration ability. And so wet mask, they may, wick or draw moisture to them, and that's not what we want. And so this is why masks should be changed and disposed of when they become wet. So the face shield will help stop that spatter and spray, especially if you're using or not using a high volume evacuation as your engineering control. But we should be. Those are going to be so valuable to us these days. And the face shield is just going to be an additional barrier between that spatter and spray and our faces. And I wanted to highlight that protection's not only for us, but for our patients as well. We want to make sure their eyes are always protected, and we may want to start thinking about their nasal passages as well, especially our immune compromised patients. And there are masks just for the nose, and they have actually eyewear that are attached to them. There's even nose filters that can dilate that nasal passage to help the patients breathe better, and also filter out those particles that are larger than 10 microns. And we've always had patients that lean back and immediately they can't breathe through their nose. And there's a lot of systemic things that are happening there. But this would actually help dilate their nasal passages so that they can breathe a little bit easier. So there are plenty of options to help protect our patient, but our engineering controls, again, like our high volume evacuation, are going to be super helpful in protecting them and us as well. So the indoor air within our dental offices, they can contain some pretty unhealthy and infectious airborne particulates, especially if we're not using those engineering controls like a high volume evacuation. And the indoor air quality contamination, it's been pretty evident for a few years. But when you look at like hospital research, it's pretty evident there. Many industries and companies have been using things like an air purification system. Unfortunately, dental offices have not yet taken that proactive step, and a lot of them, many of them, I've not actually personally worked with any myself. Air pollutants, though, they're not just infectious diseases. They can have a lot of chemical happening in there. I mentioned earlier that we're not only exposed to physical hazards, but also infectious and chemical hazards. And the chemicals in our practices, they're a concern for us. We wipe down surfaces every single patient. We use a lot of chemicals. And the dental environment, the most practical and convenient solution might be to have like a standalone air filter system, which will clean by constantly just drawing any of that polluted air and any exhausting like that clean filtered air into the room. So when choosing an air purification system, there's a lot of things that you have to consider. Cost definitely is one of them, but you also want to look at the airflow capacity and the filtration capabilities. You want to make sure it's quiet and not causing a lot of noise. And we really want to make sure that it fits the cost, but also fits our room, and again, has that proper airflow capacity for our particular facility. And then we have HEPA filters as well. And I think we're all about to come to understand HEPA and filtration a little bit more, but this is just an additional engineering control that we can utilize in our practices. You can find them again as standalone air purifiers like this one named Jade. And these particular units are available with BioHorizons and Henry Schein. And you can find out more information there. This one is actually doing 6 air changes per hour, which is pretty great. And I did want to touch on biofilm management because it's not just for the mouth. We have to manage that biofilm and water lines that we use. We create waterborne illnesses that can become respiratory illnesses, and maintaining your dental unit water lines, it's a part of our operatory reprocessing that's been established by OSHA and CDC. And you should be running your lines for 2 minutes at the beginning of the day between patients for about 30 seconds, and then doing a routine waterline testing and shocking. And there are several awesome companies out there that will help you better understand this process and make you really efficient at it. Because, I mean, if this is not designed really to make you work harder, it really isn't. It's designed to keep you safe. And if we can have a really nice workflow that includes, water running our lines, then it's going to be great for both us and for our patients. And the possibility exists that these pathogens presented in the dental unit water lines could be spread by aerosols created by our hand pieces and our ultrasonics. And they could present a risk for both the patient and the members of that dental team. And in 2016, we saw Georgia and California have cases that made many pedo patients very sick. And these lawsuits will be settled soon, but were delayed actually because of the pandemic. And it's important to test your water lines and shock them if you need. For me right now, what I was doing in this video was going through and testing all my water lines. So I test my water lines and then I check and see if they fall under the CFUs, which is your colony forming units of 500. And if I fail, then I shock. If I pass, then I continue on with my maintenance. And there's protocols out there. Shocking can be done with bleach for the water lines, not your suction. So just keep those, keep those in line. Like your suctions do not get bleach. You can shock your water lines with bleach. And there's protocols for that. And it's going to be very critical that we monitor our dental unit water lines. We want to make sure that we're always recommending or meeting the requirements of drinking water standards, which is 500 colony forming units. Or CFUs that you might see out there. And in a lot of the studies that I presented earlier, they mentioned that a lot of dental healthcare workers actually had antibodies for Legionella bacterium. So we are exposed to this ourselves. Our patients are exposed to this. And if we have immunocompromised patients, this can create a respiratory disease for them. So we really want to make sure that we're cleaning out these water lines, testing them, and shocking them on a routine basis. I want to touch on standard operating procedures, especially for aerosols. So our SOPs, or that's what standard operating procedures are called, they're really a foundation of your exposure control program or infection prevention. The goal of developing these SOPs are to reduce that risk of occupational exposures, especially when we're talking about aerosols. And when I was studying for my infection control certificate, I had the hardest time remembering SOPs. But as I walked through my clinic, I would keep saying, what's the protocol for this? Are we touching these drawers with clean hands or are we touching these with dirty hands? Are we barrier wrapping these things or are we not? Are we just wiping them down? And then it clicked in my head, okay, these are standard operating procedures. It's just the task that you do day in and day out, but everyone knows the exact way to do it to prevent cross-contamination. Because working in dentistry, it puts you at so many, potential risk and exposures to a variety of hazards. So when we're creating our standard operating procedures for aerosol management, we want to approach it in a very logical way. Ask yourself, is there a way to substitute this procedure and produce less aerosols? If not, what engineering control can I use to reduce or remove the droplets and aerosols from the environment? Do you need to be trained on those devices? Is everyone able to use those devices competently? Because we want to make sure that if we're using it properly. And if not, what do we need to do to ensure they're being used efficiently? Is every team member going to use that same device? define those administrative controls and define the personal protective equipment you're going to need when creating aerosols. Define how you don and doff, or take on or put on, take off your PPE, and then dispose of it. Where do you dispose of it? Is it in the operatory with the clinician, as it should be, or is there a bin just outside of it? Where do you put it on? Is it right outside of the room, or is it inside of the room? These are things that have to be defined. And your standard operating procedures, they're going to help the entire team understand the workflow and help to identify places where you could have infection control breaches. It also helps us to hold each other accountable as a team, because this is going to be important. It doesn't take just one person doing infection prevention. It's a team approach. And, sometimes I've developed these habits and somebody's like, hey, do you know that you're cleaning it that way? I'm like, no, God, I didn't even realize it. I was like, these routines sometimes become, just a second nature, and we go on autopilot and we develop these habits that we don't even know we're doing. And so we want to hold each other accountable in a positive way, because our goal is to prevent infection control breaches and prevent exposure. So recommendations are designed to prevent or reduce potential for disease transmission from patient to the dental provider, from the dental provider to the patient, and again, from the patient to patient. And upwards of 9 million people work in healthcare. Our health practitioners, they have an ethical responsibility to provide evidence-based and safe treatment for patients. And in the U.S., dental practices are not included in a lot of active tracking of disease transmission incidents. And the magnitude of disease transmission from dental procedures and its influence on healthcare-associated infections, it's really not 100% known. However, compliance with these established infection control guidelines, it's really a part of an ethical conduct of a dental practice so that we can avoid those healthcare associated infections. And I really hope that you guys took some pearls from this. I hope you have a better understanding of some of the engineering controls that we have in dentistry to maintain aerosols. And I really appreciate the time with you today.
Thank you very much, Michelle, for that very comprehensive presentation. If you have any questions, concerns, comments, you can add them below, or you can send us an email at webinars@henryschein.com. If you would, we'd also like you to subscribe to our YouTube channel by hitting the subscribe button below, and then you'll get all the relevant information sent to you. And as always, until we see you again, please stay safe and stay informed.